Thank you very much, Geronima. Thank you for EMAS to allow me to present this very hot subject in 2019, a subject about quality of life and following up pregnancy. Later in menopause, we may aid some saving years to our life. And I will try to prove this with a presentation today, which is addressed only for the maternal part of evaluation of the risk after gestational diabetes, but not including the offspring, which is another subject very, very important, also with an impact later in life in menopause of the new child. I have no conflict of interest regarding this subject, and I'm starting from a study published in early 2018, which was finalized in 2017, and it is another nurses study, Harvard Nurses Health Study, which proved, if it was more necessary, that pregnancy is a stress test. Pregnancy is its physiological part of our life. Menopause, it's another physiological part of our life. And the time in between, it's the time when the woman is protected by physiological endocrine environment to the cardiovascular diseases. And you will hear a lot about the risk between the glycemic part of our physiological life and then the cardiovascular risk. Actually, what Harvard Nurses Study Health Study 2, after enrolling over 89,000 women between 22 and 44 age, showed after 20 years of follow-up that actually the gestational diabetes or gestational diabetes mellitus in pregnancies and cardiovascular associated pathology in pregnancy are tied up a woman's future related cardiovascular disease later in life. And I say later because you will see another study, a recent study about mortality, which shows us that this later, sometimes it's not so late. So gestational diabetes was recognized even from 2012 by the American Heart Association as a risk of further cardiovascular disease. And the story started less than 100 years ago when Priscilla White Society and Priscilla White showed us that treating diabetes and glycemic disturbances in women improve pregnancy rate, improve quality of life, and actually give a chance for a pregnancy as an alive fetus in a diabetic woman. So if in 1924, when Mrs. Priscilla White started to teach and to educate and to introduce new technology and new insulin in pregnancy, till her retired in 1974, actually the chance of the survival rate in a diabetic pregnancy doubled from 54 to 97. So it is a life story of a woman who changed the life of hundreds of millions of women with diabetes. So her life, it is tied to improving the quality of life of the woman with diabetes and the chance to have a healthy pregnancy and an alive child. Also from Priscilla White Society, we learned from the beginning that there are two types of diabetes during pregnancy, and that's why gestational diabetes is very important in 2019, in this year, to be distinguished even more from the pre-existing diabetes. And the terms gestational diabetes and gestational diabetes mellitus, they are equivalent in this presentation and depend on which side of the ocean we are talking about studies. So they are the same, gestational diabetes and gestational diabetes mellitus, but they are different from the diabetes before pregnancy, at risk, and also at intervention, because actually gestational diabetes does not exist without the screening, and the influence and the predisposition to gestational diabetes and further in life of the cardiovascular risk of the mother and also all the other risks of the offspring does not exist if we are not thinking of gestational diabetes and we are not screening. And screening for gestational diabetes includes a new era, as you say, that we are in the HAPO world. HAPO world, it is the time after the hyperglycemia and adverse pregnancy outcome was published until now. So this HAPO world in which we are living today shows that it is necessary to do the screening for gestational diabetes to evaluate the further risk of the mother and to postpone the diabetes diagnosis of a woman. So actually pregnancy is a chance of the woman to be evaluated from this point of view, and also it's a chance of the woman to be included in a high risk group to be treated further. The HAPO study show us that not the initial gestational diabetes definition that any glycemic disturbances in pregnancy may be called gestational diabetes, but gestational diabetes it is not exactly correct, and we are looking for the new definition of gestational diabetes, which means gestational diabetes appear after 24 weeks of gestation, and any other disturbances before this should be included as pre-gestational diabetes. This has a tremendous impact, and there were a lot of talks about which is the best definition, which is the best test, and which is the best moment to do this test. About the moment, the discussion were for gestational diabetes as a screening. They were solved that everybody agreed that 24-28 weeks it is the period for screening. But which is the best test? There were a lot of debate because in the United States there were already implemented 2 steps glycemic test in a woman 24-28 weeks of gestation, and the incidence of gestational diabetes was 5 to 10% mostly. After the HAPO study, the incidence of gestational diabetes with 1 step, 75 gram glucose without water, because if we are talking about monohydrate glucose, the amount of glucose it should be tested, it is 82.5 grams, and this is another issue to validate the test in other studies regarding the glucose it is used. So incidence was going up to 18%. Is 18% the number should be screened? Are we ready for such an enormous increase in gestational diabetes mellitus patients? these were the question addressed. Anyhow, a crossover study in the American population showed that the incidence of gestational diabetes will increase so much, but also in the women at the childbirth age 1844, there were 26% of pre-diabetes stage. So IGF or IgG pre-diabetes stages, and 5% of diabetes already unrecognized. So 18, is it too much? And that's why in 2017, also the American Association of Obstetric of Gynecology and ADA, they are recommended to be used both, but mostly the ADA, it's recommended just one step with 75 gram glucose without water, unhindered, which is actually the difference between the two-step and one-step. Mostly it's the mild gestational diabetes cases. Are they related with pathology later in life? They are related firstly, we know, with immediately pathology during the pregnancy, because these undiagnosed, uneducated patients, untreated patients from the gestational point of view, they are like in the no screen group, which means that they will be discovered by the complications which are related mostly with delivery or stillbirth or risk of increased cesarean section. So these mild gestational diabetes were proved that it was to be screened. And going back of the people of the risk factors in 1917, 1918, these were the criteria for screening for gestational diabetes, not universal screening. Nowadays, with a 100 gram test, now we are screening with 75, and these women with high risk at the beginning of the pregnancy should not wait till 24, 28 weeks. They should be screened for pre-existing diabetes before pregnancy, because the women that they are screened in the first trimester with 75 gram glucose and they are positive, they are treated like pre-existing gestational diabetes. Pre-existing means not only type 1 diabetes but also type 2 diabetes, which is increasing in nowadays world. So universal screening remains, and another clue of universal screening is if the screen between 24 and 28 weeks of gestation it's negative, but later in pregnancy, in the follow-up, as we are calling ultrasound of growth and other lab reports of high glycemic index, they prove to be positive, these women should be screened even after 28 weeks if they had negative screening or if they were not participating to the screening, because gestational diabetes mellitus diagnosed during the pregnancy will improve if it is follow-up. It will improve the later in life quality of life of that woman. Is it cost effectiveness? Yes, one of the, let's say, not so nice but nice standards in UK, and they are very strict with accuracy of the intervention in terms of cost effectiveness. They show that yes, screening, diagnosis and treatment of gestational diabetes is cost effective. And even if we are going to France, where the obesity rate and the incidence of diet and Mediterranean life and healthy food, it is has a high prevalence in the society. They show that it is cost effectiveness to screen for gestational diabetes. So going back to nurses' study, what we learned? We learned from nurses' study too that the women who had gestational diabetes, history of gestational diabetes, had a 43 higher risk of developing a cardiovascular disease, any cardiovascular disease. And if we add the type 2 diabetes after pregnancy, then this increase is even higher. So without type 2 diabetes, or to prevent type 2 diabetes, and following in what we are calling now diabetes prevention program, as it has existed already in the United States, then this increase is lower. So the risk is lower by a good follow-up. Also, from the maternal fetal medicine units network, we learned that even the mild gestational diabetes, they were missed by the 2 steps, and they were discovered by the 1-step screening. It was to be done because in this mild gestational diabetes forms, it was recognized hypertension, gestational hypertension increase, and the risk of preeclampsia. And again, treating mild gestational diabetes, it was worse because in the treated group, the increase of weight during the pregnancy, it is lower, and this is an independent factor both for complication at birth and both for incidence of gestational diabetes. Not talking today about the offspring, just a little bit, but not to forget that also the offsprings which grow up and has a formation, it will be improved by treating even the mild form of gestational diabetes. So the secondary analysis of the maternal fetal medicine unit network showed us that yes, that the women who were treated or untreated in these observational studies, they were less adverse events in perinatal outcome, and also they had a decreased cardiovascular risk later in life. And when we are talking about follow-up of the pregnancy, there were numbers of studies which follow the woman with gestational diabetes, and interventional treatment, troglitazone, but now it's retracted from human use, showed a reduction in treated group in terms of time to type 2 diabetes and other complications after pregnancy, and also in pioglitazone prevention of diabetes, it was effective. But what is more optimistical, it's not only the medication, the drug treatment after, but also only modifying lifestyle, which means diet, exercise, recreation time. So both lifestyle modification and metformin also showed the same impact in a young woman after pregnancy in postponing the effects of hyperglycemic disturbances and in postponing a diagnosis of diabetes mellitus after the pregnancy, and again sparing life years in treatment sparing life years by the treatment of diabetes and diabetes complications. So diabetes prevention program, which is now covered in the United States by many health insurance policies, and also in some of the countries in Europe and South America, showed that postponing the diabetes mellitus, overt diabetes mellitus after pregnancy has a tremendously impact in cost effectiveness and in also on woman health at middle age, in perimenopause. Encouraging lactation after diabetes mellitus had also a good impact on preventing and postponing hyperglycemic disturbances of the mother, and also a good impact of the offspring, of course. So direct application of patient care, this is, let's say, is very cheap to educate, or it's very expensive to educate. I think that the doctors should pay attention directly to patient caring, to individualize each risk after a pregnancy, because after a pregnancy, at the end of the pregnancy, at the end of the 72 hours after delivery, because even in the first 72 hours after delivery, a woman may develop eclampsia and preeclampsia changes. So we may have some conclusions, and if the pregnancy, it was complicated with preeclampsia, or with gestational diabetes, or with prematurity, or with small or large for gestational age, this may have a tremendously impact of later in life of the offspring at the time of middle age. And also there are more and more data about autistic spectrum disorders in offsprings following this complication and gestational diabetes mellitus. Again, a ruling of the impact of our everyday life as gynecologists and obstetrician, which have in our hands a woman from the first, let's say, prevention from HPV from 11-12 years to physiological adolescent part with physiological pregnancy and physiological menopause. When we are talking about gestational diabetes and hyperglycemic disturbances, we have to be ready by doing the proper screening to have 15% of our pregnancies with an abnormal OGTT. Abnormal does not mean immediately insulin treatment, because just 15 of the women with an abnormal OGTT between 24 and 28 weeks, the woman with gestational diabetes will need insulin treatment. And no matter what we are doing, some 10 to 15 gestational diabetes women with pregnancy will have large for gestational age or macrosomia if it is at term. And as a practical rule, the women should be screened with venous level of glycemia, but when they will be educated to follow up their glycemia at home in their own environment, the capillary glycemia levels its 15% more, approximately 15% more than in venous venous levels of glycemia. So should be practically not to go over 100, 105 in capillary levels. What we are thinking about monitoring, because this is the key of following and education in women with gestational diabetes mellitus diagnosis in pregnancy. So close monitoring and glucose control. And we have to educate these women with dietary modification, exercise management, and insulin treatment if it is necessary. And this should be very well implemented, because a woman, if she will think that dietary modification means to eat less, sometimes in pregnancy this might be even more dangerous for the mother and for the fetus, even more dangerous than outside of the pregnancy. So the diet modification is to have a healthy diet and a necessary this is not a diet educational program, but we should know that no decrease in diet, but both quality and effective meals treatment is important, and to very slowly increase the exercise should be a balance, not decreasing the food, because this will have even more negative effect on the pregnancy. So pregnancy is a stress test for the glycemic metabolism of a woman, and this stress may help us to see which is the very weak point of a woman further in life. And when I said in the beginning further, unfortunately further, it's not so further relating the pregnancy. And in 2017, the CDC reported that in United States the maternal deaths increased. Looking at the graph with the red, so when all the other countries reported slightly decrease of the maternal mortality, in United States this tremendously maternal mortality showed us a warning sign that something is wrong, and it's happening after the pregnancy. And if you see what is tremendous, it is cardiovascular disease, or of course including cardiomyopathy and all the other cardiac disease. The good part, it is the good part of this attention is that showed us the attention on cardiovascular disease, which is associated also with glycemic disease during the pregnancy, and 59% of this might be preventable. And one of the largest preventable part is following more closely the women with obesity, with hyperglycemia, with gestational diabetes, more closely during the pregnancy, but also after the pregnancy. So this later in life cardiovascular risk might be in the first year after pregnancy, or more exactly in the first as we saw in the last slide, 44, they were in the next 6 weeks after pregnancy, so in the postpartum period. So sometimes this later it's very close. And on the recent studies we showed that in menopause the cardiovascular disease, it's exactly as it is in pregnancy, it's losing and it's increasing some risk factors. So a cardiovascular system which showed that it was very weak, or it showed that has a glycemic problem in pregnancy, with losing the protection of the balance in the sex steroid hormones, might be prone to have more cardiovascular problems. And it is a classical question to a woman why you are afraid that you will die in menopause and in perimenopause, and she will for sure say cancer. But actually the main mortality cause of the women in the first 10 years of the menopause, they are cardiovascular disease, which exceeds the man and the mean number in the menopause, immediately after the menopause. And we say that the risk of stroke and myocardial infarction it's higher immediately after and exceed the man in older age. We have also the model of ovarian insufficiency, which is tied also with cardiovascular problems, and we have also the model of PCO with infertility and ultimated as a primary, not a primary, as an ovarian insufficiency and disbalance in sex steroid, which also is tied with glycemic disturbances and cardiovascular risk later in life. So at the time of menopause, it is a moment to go back to pregnancy and to evaluate a woman and saw the problems in pregnancy if it was not already done till now, and then to evaluate if the woman has a high risk of cardiovascular disease, because a recent study show that higher HDL in perimenopause and in postmenopause may not be as protective as it was before menopause, and also the high FSH levels might influence the fat deposits and also increase the insulin resistance without the pulsatility and to maintain high levels. And also the studies which show us an accelerated atherosclerosis in vessels, they have the circumference lower than in men, so the speed of atherosclerosis in women even will increase the atherosclerotic risk. And then we are looking at the cardiovascular risk of a woman with preeclampsia, and 71 increased risk for dying from a cardiovascular event, and any other cardiovascular and risk, and also in cardiac failure. And if we are going to our subject of today, gestational diabetes, which gestational diabetes itself increase 10 times the risk of preeclampsia, then we have more increase, as it was shown in nurses study, of the cardiovascular event. And if these two will go to a preterm delivery, then this will increase more the risk of cardiovascular disease in women and with metabolic syndrome after menopause. And they are also related to small for gestational infants. The woman, the mother of a small for gestational age infant, have 2 times the risk of having further cardiovascular disease, because the same disturbances as endothelial function as in preeclampsia, or even without preeclampsia, in placental disturbances may cause cardiovascular disease and also impair glycemic function. And if we are going to a very, very recent publication from 2019, it was raised also the idea that pregnancy might not be a moment to be revealed a weak point but the pregnancy itself, it is the weakening period for a woman in which she is getting risk for cardiovascular disease. And these are studies regarding the placenta and the endothelial part of endothelial part at the level of the insertion of the placenta, the immune implication of a pregnancy, the response of the mother in terms of glycemic and also endothelial cardiovascular disease. It is a very frightening, let's say, not exactly frightening, but it is a hypothesis. It should be proved further, and also this might need, again, in highly risk women, that risk we showed at the beginning, to be seen the cardiovascular healthy, to prove the healthy status at the beginning of the pregnancy. So this hypothesis should be taken in consideration in nowadays society. And everybody knows the origins of development, that everybody starts in utero. And I'm sorry that this is not the animation, because here on the back of the medicine, in the Klimt picture, on the back of the medicine, it was death. So of course, from the pregnancy, from the birth, everybody should say will pay with the death, but the medicine will help us to improve our quality of life, to clean and to treat our weaknesses in life, and to have a high quality of life from the beginning till the end of our life. So life, it is between birth and death. Correct evaluation and correct treatment and correct education of lifestyle will improve our quality of life. And this is starting from the womb, and we are going back to the womb. And as Barker told us, the womb might be more important than a home. And glycemic disturbances, even in the absence of maternal diabetes and diagnosis, may influence the life of the offsprings and the mother further in pregnancy and further in life. And hyperglycemia in utero may tied up with tremendous modification of the offspring formation, which goes over endocrine response, which may go over the pregnancy and will have, as Barker said, later in life impact in the mother and in the father life. And this is a short study. I will say that just these 5 little mice, they were in the same utero, and the mice number A, it was on near the right uterine artery, and the mouse E, it was near the left uterine artery, and the left uterine artery, it was induced hyperglycemic status. So we saw that very high glycemic index went to the dissolution of the embryo. And all the others, the mouse number D, will also benefit from a higher glycemic index during the first day of formation. Then it will go with this rupture in the caudal at the end of the embryo, so with anencephalia and with caudal problems, and also mouse number 3. So the glycemic affected the mice according with the level of glycemia going to embryopathy from death to normal. Normal, we say that it is going to develop and go to the end at the birth. We don't know if this mouse, and we know that this mouse, after developed, even mouse number A, which had a relatively normal embryo, had obesity before birth. So we need to reinforce that the glycemia implication in organogenesis, even from the beginning of the woman life, even without pregestational diabetes, should be avoided. So glycemia before the gestational diabetes mellitus diagnosis, even before 24 weeks of gestation, may have a tremendously impact. That's why education of the women and doctors for a healthy diet should begin before pregnancy. And these women with pregestational diabetes, with type 1 diabetes, who are not seeking mostly of the time, who have no education before the pregnancy, are at risk to develop complication of the pregnancy, we know. But gestational diabetes, which starts at 24-28 weeks, also may affect the rather later in life problems related with glycemic disturbances. Now we have the technology offer us even more impact on glycemic control, and continuously control glycemic control in pregnancy, as it is. This graphic showed the glycemia from Tuesday till Monday every hour, and it's associated also with a calendar. And if the glycemic control is between the thresholds, assure mostly in pregnancy a tight glycemia index which assure the baby and the offspring and the mother for a good growth in the baby, and prevent preeclampsia and installation of the gestational diabetes and glycemic control. So we may prevent by glycemic control from the beginning, and it is another nurses studies with diet, which showed us that in the beginning of the pregnancy, if we increase the diet with fibers, we prevent it, so that in the number of gestational diabetes mellitus diagnosed in normal pregnancy without obesity decrease with 3 till 5%. So starting this glycemic control from the beginning may prevent even the gestational diabetes mellitus in pregnancy, which is a good news because we can control the lifestyle. I put this because it was last week, this American Diabetes Associated session in San Francisco, and one of the warning was related to hypoglycemia. And if we heard that, I was very often said hyperglycemia instead of gestational diabetes, everybody thinking that it's high, the glycemia is very high. Actually, when there is a disturbances in glycemia during the pregnancy mostly, but also in later in life, the people are thinking that it's really strictly related with diet, and sometimes they think that eating less it's the clue of the treatment. But no, hypoglycemia in pregnancy, it's associated with stillbirth. Hypoglycemia may induce and may reveal other metabolical pathways that will add further risk, mostly in pregnancy, but also later in life. And that's why the clue, as I said, is diet, but not eating less in pregnancy, not eating less in later in life, eating better. And this is tied to hypoglycemia. You see here that there are important studies which showed us that the people already with diabetes have a risk more of cardiovascular disease if hypoglycemia. It's a very event, frequent event in their life. And in pregnancy, hypoglycemia it's associated with an even more risk of the offspring and of the stillbirth. There are people who are trying to get better and easier way of classifying the glycemic disturbances related also with the intervention with the risk, not only in pregnancy but also after pregnancy, and these are 5 types of diabetes. It is a very, very expensive way of stratifying this with glutamic acid decarboxylase antibodies with GADA, but showed us in this type 3 and type 5 actually they are type of glycemic disturbances which are more related both with gestational diabetes, pre-pregnancy status of a woman with high risk of gestational diabetes, and also later in life the woman with gestational diabetic and metabolic syndrome will develop. We should not forget the pancreatic dysfunction, and this diabetes and diabetes mellitus sometimes in pregnancy. In thin women we are seeing gestational diabetes mellitus, and we have to think about the chronic pancreatitis, which is an absolutely pancreatic disorder also associated with exogenous function. And we should think about this because the relation and the complication in pregnancy, both from the gastrointestinal symptoms which might be superposed with the pregnancy related gastrointestinal, let's say, physiological reaction, might be confounded, and also might be confounded with a type 2 diabetes or gestational diabetes, and they have treatment and also with insulin, and also more easily with insulin, and also important risk related further in life. Relating hyperglycemia also in pregnancy and progression to type 2 diabetes, it is shown that liver function should be followed out closely in pregnancy and also after the pregnancy, because Herring Hu proposed in 2015 that the fatty liver superposed with glycemic weaknesses in women with gestational diabetes, but not only with gestational diabetes, may be a key in prevention type 2 diabetes. The studies they have an underestimated number of women with gastrointestinal problems, but this fatty liver should pay attention around the menopause in a woman with gestational diabetes, and treatment of the fatty liver, let's say, will improve and will postpone the type 2 diabetes of diagnosis. It is another type of insulin resistance, which is started with brain insulin resistance. And in this, we are going back to the early stages of brain when it is a formation of brain in the first part of the pregnancy, actually in the first week of the pregnancy, and this is very much tied to the formation in early pregnancy. I choose this DALI study just to make a little bit relation with obesity, because I cannot stop this gestational diabetes warning presentation without talking a little bit about obesity, and these interventions are less effective in a woman with obesity, because obesity it's an inflammation stage, and I will compare obesity with type 1 with pre-pregnancy diabetes. Pregnancy, it's again a inflammation state, and with a lipid transfer to the baby. In the presence of obesity, it is very high in the first part of the pregnancy. So in the fetal compartment, this lipid exposure and lipid very early change from lipolysis to lipogenesis will affect the baby from the formation part in the brain, in the pancreas, and this will be the babies, the mother. These babies will become mothers with increased risk of gestational diabetes and cardiovascular risk further in life. So the origins of obesity, they are stays in the babies with a mother with obesity. So it is a sort of feedback. We cannot stop without changing our lifestyle, and changing our lifestyle have also a social and a health policies impact, because the obesity now it's getting an epidemic, and many doctors know the terms of epidemic of obesity and diabetes. And also changing lifestyle showed us that in the cities and the lifestyle in the cities tied us to have an urban diabetes, so a lifestyle which favorized the obesity and diabetes. So the women that are living in town should change even more from their lifestyle and their intervention. There were studies and intervention in Barcelona and Chicago. They showed us that they improved the lifestyle, postponing diabetes and also gestational diabetes mellitus. It's increase in the pregnancies for the women who are living in large urban areas. So starting from our everyday life, from a physiological period of our life, which is pregnancy, going to menopause, which is another physiological life of our life, and a physiological period of our life, but later we may learn to decrease the risk just by education, just by diet, just by exercise, and a continuous follow-up of our patients to improve the quality of life, both from an individualized risk assessment and from healthy policies like general healthy policies like diabetes prevention programs. As EMAS said, our mission is to promote health for women and men in midlife and beyond, because the newborns are 55% men and 49% women at birth. I will go now, after 55 minutes, to the question and answer part. And Geronimos, please tell me how much time should I let the question on the screen?
Yeah, so basically, it's up to delegates because right now I can see that we have additional questions in the chat box, and I don't know, can we maybe leave 1 minute for your
Yeah.
questions each? So it will be
Yeah.
3 questions, so it will be
Yeah.
3 minutes, and after that we can move on to the additional questions from the audience. Is that okay for you?
Yeah. Yeah. Thank you. Thank you.
Okay, perfect.
So I think that this number one question had 1 minute, let's say, because it's
Yeah.
basic. And yes, the answer it's of course needs for screening. Without a screening, we may have just opportunistic gestational diabetes mellitus diagnosis. Okay, and now I will go for question 2. And okay, I think that it was enough. Of course, that all the main attitude is glycemic surveillance and diet with exercise, and not all of them. Just 15% will have insulin treatment, approximately, depending in different population. And hyperglycemia not always should be treated. It's a physiological hyperglycemia. Exercise and diet are the key of the treatment. And yes, also the diabetes in the family does not imply insulin. And now, okay, we will go for next, the last question. Okay. It was now it was 1 minute. Sorry, I took some from the audience. It was okay. I think that there are some minutes. Of course, all of above they are true. Okay, and Geronimos. Okay.
Yes, thank you for the questions and answers. And we have one question from the audience so far. So it is a question by Dr. Mick van Trotzenberg, and the question
Yeah.
is: in women, high testosterone levels are associated with type 2 diabetes. Is there also a linkage of elevated androgen levels in pregnancy and gestational diabetes?
Yes, thank you, Mick, for this question. In pregnancy, we know that there is a disturbance, let's say a physiological modification. It's not always the it's not a pathological part, but we have as an example the PCOS. They have high testosterone. In pregnancy, they are one of the first associated with gestational diabetes, but not only with gestational diabetes. So as the risk factors imposed, they should be screened in the first trimester for the risk of pre-existing gestational diabetes. So following this example, testosterone, there is no study that I know related with the high testosterone levels in tested in women and then related with gestational diabetes. Because of these physiological changes during the pregnancy, the testosterone levels and also the progesterone levels, which may further go to affect the levels of testosterone and estrogen. So the progesterone is the hormone of the pregnancy, progesterone, and testosterone levels. They are not specifically increasing all the pregnancies. So testosterone in the first trimester and before pregnancy are tied to glycemic disturbances and with a further risk with obesity and with fat predisposal. Also, we have another pathology which is related to the pregnancy and has a tremendous impact of the pregnancy, the so-called congenital adrenal hyperplasia, that it's a genetic also factor and it's associated with hypertestosteronism. And if the testosterone is very high in the beginning of the pregnancy, it should go to the virilization of the female fetus. So the external genitalia, which are completely formed at 9 weeks of gestation, so the phallic urethra, it is completely closed at 9 weeks of gestation, and the child should be a girl with external genitalia as a boy. And I know that Mick is the specialist in this, so I will not explain. But also in these pregnancies, the treatment, it is and it is shown to have some results of decrease impact of testosterone. In these pregnancies, we administrate dexamethasone as a prevention of virilization of the female embryo. And these pregnancies in women with congenital adrenal hyperplasia, they showed up to have more gestational diabetes and obesity than in normal pregnancies. So maybe the testosterone influence, it is important also in this part. But usually this adrenal hyperplasia has also other steroid modification, which cannot be, let's say, put everything on testosterone modification. So there are other passes that impose testosterone and decrease of steroid normal levels. I hope that with these two examples, it's okay if Mick wants to ask me.
All right, thank you so much. I think that we do not have more questions. So thank you so much, and this concludes the presentation and the webinar. Thank you so much for a wonderful presentation, Professor, and all the attendees for being here today. Thank you, everyone, and have a great rest of the day.
Thank you very much, Geronimos, for your help, and thank you, EMAS, for the opportunity of presenting this on the webinar.
Thank you.